Assalamu alaikum. Good day and welcome to day 2 of our symposium on oral head and neck cancer awareness. I am Dr. Ghazala Naveed, Managing Director at Pride, and I'm honored to continue our discussion on this critical topic. Yesterday, we explored various aspects of oral cancer, and today we'll delve deeper into the latest advancements and strategies for prevention, diagnosis, and treatment. Fellow professionals, it is our distinct pleasure to introduce our honored speaker, Professor Dr. Mirza Abdul Rauf, Principal of Islam Dental College, Sialkot. With a distinguished career spanning multiple facets of academia and clinical practice, Dr. Rauf brings a wealth of knowledge and experience to the field of oral and maxillofacial surgery. As a seasoned educator and clinician, Dr. Rauf has held various leadership positions, including professor and head of the OMFS department at Islam Dental College. His expertise extends beyond academia, with visiting consultant roles at prominent institutions such as Islam Teaching Hospital Sialkot and Iqra Medical Complex, Wazirabad. Dr. Rauf's impressive background also includes serving as assistant professor and head of the OMFS department at Sharif Medical and Dental College, Lahore, and Registrar King Edward Medical College, OMFS department at Mayo Hospital, Lahore. Today, Dr. Rauf will share his insights and expertise on the topic, Unmasking the Menace, Squamous Cell Carcinoma of the Left Maxilla, a Case Study. Please join me extending a warm welcome to Professor Dr. Mirza Abdul Rauf. Sir, you may take the mic.
Thank you very much. Thank you. Thanks a lot for my introduction. Good girl. I want to share over here what different problems, misery, and adverse effect, complications due to late presentation and diagnosis of squamous cell carcinoma. Patient name, Khalik. He was 67 years old, presented to our department with history of swelling in his left side of palate. 3 months back, he noticed this swelling. This swelling increases with the passage of time. It was not painful, neither tender, but as it was increasing, it was causing mobility of the teeth from maxillary left center incisor up to the last molar. When he presented to our department, we decided for incisional biopsy for the confirmation what it is, what is the histopathology of this lesion, and what is the grading of this lesion, and how we can stage it, how we can operate it, should we operate, and what will be the outcome of this case. So, incisional biopsy under local anesthesia was done, and specimen was submitted for histopathology, which shows that it is moderately squamous cell carcinoma. Then, preoperative assessment was done by the anesthesia department, and different preoperative investigation, including blood complete examination, urine complete examination, X-ray chest, PA CT scan, and RFT, LFT, ECG, echo, blood grouping, and cross-matching for 2 pint of blood was done. Taking clearance from the anesthesia department, we plan to operate this case on 4th of November 2024, where we have done maxillectomy of left side because a tumor was large and extra oral approach was adopted through Weber-Ferguson incision. After raising the flap and exposing this tumor, left maxillectomy was done with maximum safe resection, and then because the lymph node, submandibular lymph node, and jugulodigastric lymph node were palpable at that time. At that time, they were palpable. That's why selective uh, radical neck dissection was also performed. We again submitted all this resected tumor uh, to the histopathology department, and that is the photograph of his submandibular gland, and that is the photograph of the patient on first post-operative day. Yes, that is. Please wait. That is the first post-operative day. All wound has been closed primarily, and you can see that drain is still in his neck. Next slide. Next slide. That is the uh, condition of the patient on third post-operative day, where dressing has been removed. Everything was good. There was no addition of the suture. And during this time, before surgery, one call was also sent to the prosthetic department, where model surgery, they taken the impression, and then model surgery on this patient model was done, and pre-operative, pre-surgical uh, prosthesis was prepared, and that is the condition of the patient, intraoral wound condition, and that is after that's. Thank you, Dr. Ghazala. That was the on seventh post-operative intraoral wound condition of the patient. There is no residual tumor, there is no problem, but there is a big oral deficit. And patient was, what was the problem? Patient was unable to chew, unable to drink anything. And later on, I will show you what type of services has been given by the prosthetic department. Next slide, please, Dr. Ghazala. Yes, that is the condition of the patient on 14th day postoperatively, where all suture has been removed, and that is the about the mouth opening, about his extraoral wound, and wound of the neck. Everything was good regarding surgery. Next slide. That is the evidence that we have done tumor-free surgery. All his tumor, that is the mesial, that is the distal, that's the interior, that's the posterior, all margins were free of tumor. That is the documentation, that is the evidence that tumor-free surgery has been done by our team in our department. And next slide, please. Now, then, because we have done palliative surgery, please remember, because it was stage 4 tumor, and we have palliative surgery. That's why then we have gone for the CT scan, follow-up CT scan, which shows that there is no residual tumor. Uh, but we have sent this patient to the oncology department for further management and expert opinion, where they have advised this follow-up CT scan, and that is the report. And on this CT scan report, they have decided that 30 doses of radiation they will given to the patient in head and neck region. That is again misery, and I will discuss at the end what are the misery of late presentation. Okay, next, please, Dr. Ghazala. Next slide. Now, look at that is the that. Photograph has been taken just 4 days back for latest photograph, which is showing a patient has a deficit in left maxillary area. Mucus is present over there, and I receive just today. You can say that 6 days back, our daughter called me, Doc Saab, our father has a yellowness in his palate, what it is. So that, and I explain them that in a normal patient, mucus secretions, they have a proper drainage. But when we have resected his half of the maxilla, normal function has been hampered, and that is one of the misery. He is unable to swallow, unable to chew, and unable to talk, dysphonia, dysphagia. Uh, these are the problem to this patient. Please, next, what? Yeah, that is the reason. That is the reason. Look at now, nice services given by our prosthetic department. We have a young and trained expert senior registrar, Dr. Anza. Then she has taken the impression of this patient, and his obturator was refabricated, readjusted. That is the evidence what we have done. Next slide, please, doctor. Please, next slide. Now, you can see over here when he's wearing his denture, when he's wearing his obturator, and he's comfortable. Regurgitation of the food and fluids is not happening, and that's photographs showing that how nicely this obturator has been fabricated, prepared by prosthetic department. And that is the one example. When you work in a team approach is more effective and more better as compared to the one-man show. And please proceed, Dr. Ghazala. That is the photograph, the same patient, his extra oral profile. You can see how much sorrow, how much pain, how mentally stress having this patient. You can see by his eye, but we are giving him and we encouraging him psychologically, physically, medically. We are doing our best. Even then, you can see how much he is disturbed. That is the last photograph, and that is we have taken that 5 month and 5.5 month total time has passed from the day one to the last day, and you can say you can see asymmetry in the face. Right cheek area is prominent, left side where we have resected his maxilla, and that is depressed. It is like that. The message for today is because all we know why we are conducting all, and we are prepared, we are sharing our experience, our knowledge, our expertise. Uh, what is the reason? What is the reason? Reason is this one. Uh, take messages. Tip of the day. Proper tip of the day is please uh, discuss in your family, discuss in your colleague, because why from one person, that is the man or woman, then they gathered in a home, that is a family. When this home is gathered, then that is the community. And then all this one, you go for the further and further. Dr. Gazala, your time is right. Either I'm talking more.
No, you have ample time, sir. You can speak.
I
You have
have a
ample
time
time.
to
Yes,
elaborate
yes,
my
yes, sir.
is
Yes, sir. Yes, sir. You have
okay.
ample time. You
And
can speak.
people are able to listen me properly or not?
Yes, sir. People have been appreciating your presentation. It was very informative and very clear. So we also have a few questions. When you're done, I can start with the question and answer session
Okay.
if you're ready for that.
So I'm talking about uh, what is the message I'm saying that in literature it is written that the ulcer which is not healed within 14 days must be biopsized. Please, during telling this story, that person, he was running a hikmat clinic, and first he go for home remedies, then he was go to some quack, some the pharmacy, and like that, then untrained person. And then during this precious 6 month he wasted, 6 month he wasted. That's why when he presented to our department, tumor was stage 4, and spread to his neck. And that is the reason we have done palliative surgery. To please, I will emphasize, I will request you, I will share with you this story. Please spread this message to all community uh, uh, regarding early detection, early diagnosis. Then results are good and excellent. Uh, that is the way. If you want to ask any question, I'm here. Dr. Gazala
Yes,
may
sir. We have a
assist
few
us.
questions. Yes, sir. We have a few questions. Can squamous cell carcinoma be cured completely?
Good girl, ji. Very difficult question. uh, with At the moment, people are working continuously, and squamous cell carcinoma histopathology is progression, is spread, very very complex mechanism. uh, all we know that predisposing factors, that is tobacco, that is alcohol, battle net, and human papillomavirus. Please, I request over here, because it is for prevention. Then ask the person to avoid all these predisposing factor. And regarding this, as you ask me, can we cure it completely? I will take the support from our Holy Quran verses, and that is the Wal Asr. Allah is saying that Innal insana lafi khusr. a human being is continuously deteriorating, but illallazina amanu, person who have believe in Allah and His Prophet and doing good deeds, illallazina amanu aminu salihat watawasaw bil haqqi watawasaw. Then we can talk about it. Otherwise, it is very difficult to cure expectation of. You can say yes, early detection and prevention. That is better way. Otherwise, answer is no. You may next
Okay, so
question,
sir, we have
Dr.
a few more
Ghazala.
questions. Yes, sir. This Dr. Saman, she is asking, what is the recurrence rate of squamous cell carcinoma? Dr. Rubina Shehbaz is asking actually. What is the recurrence rate of squamous cell carcinoma?
Gurgalji, that depend upon the stage, stage one, stage two, stage three. And normally, it is written in the literature that the 3 to 5 year survival rate is simply uh, 50%. 50%. Uh, uh, uh,
Okay.
and what they have done, what they have noted, what they have mentioned, stage one. We are talking about stage one. I have seen if so most of the time we mm, reply that it is unoperable case. We send straight away to the oncology department. That is the very notorious tumor, and throughout the world, 4% in 100,000 is the ratio, and where there in South Asia and where there is more consumption of alcohol, tobacco, battle.net, and this is increasing more and more. Recurrence rate is high where there is
Okay, so sir,
and then stage one, stage two, that is the in first 2 days person has to discuss. That's why we are stressing upon, that's why we are emphasizing, that's why we are talking, why that's why we are conducting symposium, please, on for early detection and in stage one. You, next question.
okay, sir. So Dr. Fatma has asked a modified question, the same question. Okay, is there a comparison between the recurrence of squamous cell carcinoma after treatment if the factors are removed or if they are not removed? Factors in the sense if the person was addicted to nicotine. If those factors were removed, does the recurrence rate falls down or does it stays the same?
Good girl, ji, because these predisposing factors already has changed the genetic material. They have worked on the genes. Uh, that, that's why after uh, resection, after discontinuation, uh, recurrence rate will be the same. As I have told you, because prevention is better than cure.
Okay, sir.
Because when genetic material has been changed, apoptosis at the level of apoptosis at the interleukin alpha 1, when these changes has been already occurred, they will continue. The genetic engineering is required, doctor.
Okay. So, sir, there's a question by Dr. Saman. She's asking, what rehabilitation support needed after squamous cell carcinoma treatment?
Nice question, good girl. Have you seen that I have mentioned that is not one man show. That is the team approach. Simply looking at this patient, in this team, maxillofacial surgeon, anesthetist, prosthodontics, then speech therapist, psychiatric, That is the team approach. We all have to play an important role in the rehabilitation of this patient. We are encouraging. Even then, in one member, fam, a patient, family member, and one, I will give the importance to the patient. I have throughout my professional life, the person who has a strong will, they cure themselves earlier as compared to the frightened and COVID person. So that is the team approach. That is the team approach. As have you seen in the future, if because palliative surgery has been done, even then there is no residual tumor after 5.5 months. Uh, when tumor appear or before 6 years, then we call it residual tumor. And if it appear in its primary site after 6 months, then we call recurrence. So there is no residual tumor. Even we have done palliative surgery in his primary site. There is no residual tumor. Uh, we are waiting. And then the oncology department, where radiation has been done. And during this time, a patient was very uncomfortable, unable to chew, unable to swallow, unable to speak. And the family members, doctors, radiologists, each and sisters, paramedical staff, each and every person did their very important role. And then this patient has been, we are presenting you at the moment.
Okay.
Next question.
So, sir, Dr. Sana is asking, can stress or high cortisol levels speed up this process of squamous cell carcinoma? Can stress levels dictate the squamous cell
Um,
carcinoma progression?
Dr. Zala, please,
Yes, sir.
line was dropped. Please ask what you are
Yes,
asking.
sir. Can stress increase the levels of, can speed up the process of squamous cell carcinoma? Can squamous cell carcinoma process increase with high cortisol or stress levels?
Uh, okay, the person who is using a predisposing factor like alcohol, and uh, in that person, known person, I'm asking first, because I'm give the correct answer. Known squamous cell carcinoma patient, or the patient simply under stress and he developed what she's asking. My question is, what does she want to ask?
Sir, we have another question for you. Doctor Triple A is asking, Dr. Rauf, you have not discussed post-op complications in this case. Please discuss about it in short. And does the age of patient matter in this case?
Nice. Good girl. Now, he's got very valid question. Might be he has not listened. I have discussed complication. These were the complications. But that's why I'm unmasking. I'm telling. I'm unveiling. Telling you what are the problems. A lot of complication like that. His normal function has been hampered. He's unable
Yes, sir,
to
you mentioned
speak.
it
He's
earlier in
unable
your
to
slide. Yes.
swallow. He's unable to drink. These are not these are the not complication. Okay, if you wanna see about his health, he was in usual state of health regarding his respiratory system, regarding his urinary genital system, regarding his CNS. What what complication you further wanna should I narrate? I can narrate it.
Sir, I think he joined late. That's why he missed that slide. So, sir, we have a few appraisal messages for you. Dr. Amir Zada is saying, I have listened to many speakers and have personally delivered numerous lectures. Sir, he's also a speaker. on various case studies, but your method of presentation is truly exceptional. Thank you so much, sir, for joining us. It is an honor for Pride to have you. And then we have another praise from Dr. Farooq. He's saying, sir, your knowledge is mashallah, and the way you have delivered the lecture, it seems like we're listening to an international panel talk of surgeons. So everyone is actually appreciating your way of delivering the lecture.
Thanks a lot. Thank you very much. That is just because of I want to share one thing. What is when I was student, my professor uh, discuss with us and give the statement, you people are my driving force. If you will ask the question, I will make more practice, and I will be perfect. So thank you very much. When you are asking the question, I have to prepare, I have to uh, uh, streamline my knowledge, then I able to. Thanks a lot. Thank you very much. I
Thank you
thank
so
you.
much, Dr. Rao, for your very insightful session and for sharing your knowledge. We are honored to have you with us, and I hope that we have more
Thank you
sessions with
so
you
much.
in future. Thank you so much, sir.
Thank you. Thanks a lot. You're welcome. Always welcome. If I can give any kind of services for you, it's honor for me. Thank you. Thanks a lot. And I
Sir,
would
it's our
say
honor to have
that
you.
was a very, very good way to conduct it, and to for the regarding awareness of squamous cell carcinoma, efforts by your organization, by all you people. You are well equipped, well trained, well knowledgeable, and you are conducting it nicely. Best of luck for your future. Goodbye.
Thank you,
Allah
sir.
Hafiz.
Thank you, sir.
Thank you so
Allah
much,
Hafiz,
sir,
sir.
for your wonderful lecture. Thank you for answering questions
Welcome,
elaborately.
Dr. Salman Ashraf. I can see Dr. Salman has joined. So, Dr. Salman, please carry on. Yes.
Thank you so much, sir. We are very grateful for your time, for your presence. It was truly insightful and added great value to our symposium. Thank you so much, sir, for answering the questions elaborately. We are truly grateful for your time and contribution. Thank you very much, sir, once again. Allah Hafiz.
Thank you so much, Sir Dr. Mirza Abdul Rauf, for that insightful presentation. It's always a pleasure to learn from such depth of experience and clarity. Assalamu alaikum and a very warm welcome to everyone joining us today. I'm Dr. Ayman Liaquat, serving as a regional director at Pride. It's an honor to be your host for this important session in our virtual symposium on oral head, neck, and cancer awareness campaign. Today, I have the privilege of introducing a distinguished speaker whose clinical and academic contributions to dentistry are truly commendable. Dr. Salman Ashraf Khan is a name synonymous with excellence. He holds a BDS degree and is a fellow of the Royal Australasian College of Dental Surgeons, Australia. He currently serves as an associate professor in operative dentistry and is the former supervisor of the MDS program in operative dentistry. Since 2012, Dr. Khan has been a consultant dental surgeon at Shaukat Khanum Memorial Cancer Hospital and Research Center, Lahore, where he plays a vital role in the dental care of oncology patients. He is also a certified clinical speaker for Dance Place Sarona, representing leadership in clinical education. His interests span aesthetic rehabilitation, dental trauma management, and care for medically compromised patients, all directly relevant to today's theme. Please join me in warmly welcoming Dr. Salman Ashraf Khan. We are honored to have you with us, sir.
Thank you very much, Dr. Aman, for this nice introduction. Here, I would also like to congratulate the Pride team for putting up a great show and making an effort to enhance the knowledge of our participants of this symposium. Bismillah Rahman Rahim. So, I come from this renowned hospital, Shaukat Khanum Memorial Cancer Hospital. There's one thing about this hospital is the JCI, Joint Commission International Accredited Institution. We have very few institutions in Pakistan, and this is probably the second or the third institution in the world which has enterprise accreditation, which means all its institutions throughout Pakistan, they have patient safety standards according to the Joint International Commission. So, whenever the patient is diagnosed with cancer, it is usually a sudden diagnosis. So, and at that moment, uh, uh, especially in head and neck cancer cases, and in also in other cancers, sometimes the dental health has something to do with the overall management of this patient. Let's discuss the different types of the tumors that we have and how they are managed and how our role comes in. So we broadly divide these tumors into solid malignancy and hematological malignancies. Under the solid malignancies, we have the breast cancer, lung cancer, colorectal, prostate, head and neck cancer. These are usually treated with either of these or a combination of surgery, radiation, and chemotherapy. Among the hematological malignancies, we have leukemia, multiple myeloma, and lymphoma. So their primary management is chemotherapy. In cases of lymphoma, there is a role of radiation therapy as well. Any cancer management can have local or systemic effects on that person, right? So local is any surgery is done, that local area will be affected. The functions of that part of the body will be affected. If any radiation is done, especially to the head and neck area, that will have its consequences. When we come to the systemic effects, systemic drugs, they affect almost all or most of the cells of the body, which are rapidly multiplying, especially in case of the chemotherapy. And then there are certain drugs which prevent bone degeneration, and these drugs can have a role, can have a sort of a debilitating role in causing osteonecrosis in the patients. So if you look at dentists, the dental community, they have a very significant role in in sort of helping these patients to grow through their disease process and go towards health, right? So we as dentists have a more of a supportive role in cancer patients. But there is one experience that I have gone through, and that when we send our patients to the GDPs, which are outside of the hospital, most of our GDPs are not sort of skilled enough, or they are not confident enough in managing the cancer patients. So today's talk will be a little glimpse of how to go about. So cancer management can be done the dental management of these cancer patients can be done prior to cancer therapy, during cancer therapy, or following the cancer therapy. A patient may be referred to a dentist who has been diagnosed with cancer for a dental clearance, and this dental clearance may be required for a bone marrow transplant, for a head and neck irradiation, or bisphosphonate therapy, right? So people who are outside of the hospital will get more patients for head and neck irradiation clearance or a bisphosphonate therapy. So when we get when a dentist gets a patient who has a history of cancer, the dentist must look into the type of the cancer and the treatment plan provided by the oncologist, the medical history of that patient, any medication history, or the dental history, and the dental history. So in all situations, we need to communicate with the oncologist of that patient. A good oral hygiene is the fundamental of any dental management that we have to do. What I've seen is most of our patients, as a nation, our patients only brush in the morning when they get up. and they have their breakfast in a few minutes after that. So you have to tell them to brush twice a day after breakfast and before going to bed at night. Modify their oral hygiene instructions so that they can comply to it. Then comes your comprehensive dental assessment and treatment planning. So when we ask our patients who have been recently diagnosed with cancer that they need dental screening or dental clearance, or in certain situations invasive dental management at a very short notice, these patients are very reluctant to have that done. They are already going through the shock of the cancer diagnosis, and they are not very keen to have all these dental managements done. So we as dentists have a role to sort of convince them, to give them the knowledge, required knowledge, and to try and make them get this treatment done. So what are the integral components of your comprehensive dental assessment? That is clinical evaluation, especially after air drying with good magnification and illumination. Do a basic periodontal examination. If needed in that, you may go for a detailed periodontal charting. In your radiographic screening, get your OPG done. Posterior bite wings should be done. With all this information, you may require some selected periapical radiographs to be performed. And in very selected cases, you might require a CBCT scan. So this is all that needs to be done by a dentist. Any oral prophylaxis is sort of mandatory for these patients before they get into a cancer management. Any acute dental issues, they must be managed before the patient goes into. So any tooth which is giving them pain must be addressed. We would like to extract hopeless teeth preferably 3 weeks before a cancer therapy begins. And in situations where a tooth has a potential for extraction down the road, these, especially in cases where we are going to give bisphosphonate therapy, these teeth should be extracted beforehand. So, and dental management of restorable teeth should be ideally be performed. Sometimes we do not have enough time for it, but this can be done down the road also. Any prosthesis should be well checked, and if it can cause any sort of a mucosal trauma, it should be addressed. Maintenance protocol for these patients 3 to 6 monthly should be followed. So there's the clinical recommendation that whenever possible, teeth with dubious prognosis are removed no less than 10 days prior to commencement of cancer therapy, right? So patients who are undergoing radiation therapy, especially, all dubious teeth should be extracted at least 2 to 3 weeks and no less than 10 days. To go into a little deeper management, in a detailed management, this is information by the Multinational Association of Supportive Care in Cancer, International Society of Oral Oncology, and American Society of Clinical Oncology. They have given this guideline on how to manage these teeth. So whenever a patient comes to you for dental clearance, we would ideally like to go for a complete dental clearance, right? Sometimes we may go for a partial or a minimum dental clearance, right? So in complete dental clearance, we are treating everything, right? We are restoring all teeth, all cases with severe cases, pulp involvement in dental abscesses might require a root canal or an extraction. Any tooth with apical periodontitis may be extracted, retreated, or epicoectomy may be done. In cases with the advanced periodontal disease, we want to extract teeth with a probing depth of more than 6 millimeter or equal to 6 millimeter, percussion involvement grade 1 to 3, or severe inflammation. Partially erupted teeth may be extracted, but usually we do not have enough time to manage all these things. So we may go for a partial management, partial dental clearance, which means we are restoring caries which have mild to moderate extent. We are treating apical periodontitis of all lesions more than 5 to we are treating only symptomatic lesions and lesions with more than 5 millimeter dimension, right? Or observe asymptomatic lesions which are less than 5 millimeter in diameter. About perio cases, we want to extract all teeth with more than or equal to 8 millimeter probing depth and grade 3 mobility or severe inflammation. We want to observe asymptomatic partially erupted teeth and extract erupted third molars with purulent or symptomatic condition. So this is something we may go for if we have optimal time. We may go for this. And if in rare situation, the oncologist wants to start the treatment straight away, in that situation, we are only managing the symptomatic teeth, nothing else. So we want to put the patient, we know that in most of the cases of cancer management, there will be some sort of xerostomia, and this is going to affect enhance the decay in the teeth. So you want to make trays for this patient and ask the patient to use neutral pH sodium fluoride gel 1.1% for 5 to 10 minutes daily. Uh, Remove the tray, do not spit, do not brush out immediately after that, and do not drink or eat after 30 minutes for about 30 minutes. We want to avoid an alcohol containing mouthwash, chlorhexidine mouthwash. You may use a mouthwash which does not contain alcohol. One very good thing, especially in cases with xerostomia because of radiation, we may use mouth rinses with in a liter of warm water. We put 1/4 teaspoon of baking soda and salt. Shake it well and ask the patient to do frequent rinses with this. This has a lot of beneficial effect. It has a bland taste. It is antimicrobial. It has good buffering ability. It is cost effective, safe. It has minimal abrasiveness, and long term use can be done. So our basic aim or objective for any dental management prior to cancer therapy is improved oral health, uninterrupted completion of cancer treatment. Because if you are left with teeth which may become symptomatic down the road because of the cancer therapy, you might have to delay or halt the cancer management, which can have its own adverse effects on that patient. There are lesser chances of severe oral complications, less risk of developing osteonecrosis, less financial burden, and improved quality of life. So then sometimes it happens that while the patient is going through the cancer therapy, they might respond to us, report to us. So in these situations, we do not go for any elective procedures. We only go for any acute trouble that we get. Oral hygiene management and all the topical fluoride application is part of the management. So whenever a patient gets a chemotherapy is a drug which affects almost all cells of the body, especially those cells which are rapidly multiplying. So because it has a myelosuppressive effect, it causes neutropenia. It may cause neutropenia, and even it can cause it might require the admission of that patient into the hospital. This immunosuppression will has a potential to flare up the dental issues which were silent beforehand, right? So if a patient comes to you who is undergoing chemotherapy, You need to ask the oncologist about the type of the cancer, which chemo drugs are used, what dose is used, how often is the chemo cycle. The chemotherapy cycle may be for 21 days, it may be a 15-day cycle, it may be a 7-day cycle. So usually a 21-day cycle. In a 21-day cycle, the patient starts recovering after 12th or the 13th day, right? So there you have a small window where you may manage acute situations. So if the patient comes before this, you treat it with antibiotics. And once the patient's counts improve, the blood counts improve, you may go for the management before the next uh, chemo cycle starts. It's difficult to do this sort of a thing in a patient who is undergoing a 15-day or a 7-day chemo cycle. In that situation, you need to talk to the oncologist, delay the next chemo dose, get the dental management done, and then resume the chemotherapy. You also need to ask about the past cancer treatments, the patient's age. Older patients are more prone to infections, and they takes more time for them for recovery. Patient nutritional status also carries a role. So, in a patient who undergoes chemotherapy, there might be viral or fungal infection, there will be xerostomia or mucositis. So, this is a patient, a young patient who was undergoing chemotherapy and developed mucositis because of unexfoliated remnants of the deciduous teeth, right? This is a situation where chemotherapy can cause mucositis in the oral cavity. This resolves down the road, but in the early part of the chemotherapy period, this might require some management. So elective dental treatment is avoided whenever possible during the cancer therapy. So when you have such a patient who's undergoing chemotherapy, you always want to get a fresh CBC before you intervene in that patient. You want to have a platelet count, ideally a platelet count which is more than 50,000. You want the white blood cells count to be more than 2 into 10 raised to power 9 and erythrocytes more than 5. So if the platelet counts are low, you might require infusion. If the white blood cell counts are low, you might require antibiotic prophylaxis for this patient. So this is something which is important. If the counts are not optimal, we want to defer invasive dental management and prescribe antimicrobials, wait for the counts to recover, and then you may go ahead with your management. So this is a breast cancer patient case. Patient had dents in vaginators, developed palatal abscess. We managed with antibiotics in the initial phase, and then we went in for endodontics. Intercanal medicament was placed, and down the road, obturation was performed. This is another situation where the patient had fixed acrylic partial dentures on the teeth, and because the chemo caused the immunosuppression caused flare up, the patient even had some palatal bone sequestrum formation. You can see here it came off down the road, so we had to halt all chemotherapy, put the patient on antibiotics, let this whole thing recover, and it took a while. It took about a month or so for this patient to recover before we could go back to chemotherapy. This is another child, a 3-year-old child with having leukemia, and they had febrile neutropenia and developed this necrosis of the soft tissue, the attached gingiva, and again we had to halt, put the patient on antibiotics, especially metronidazole. Uh, Once the counts improved, the patient's situation improved, and this whole he lost his upper right one and the upper right one tooth and the mucosa around it. So these sort of situations do happen in cancer patients, and we have to be careful. So do I have more time to discuss the radiation therapy, or do we need to stop here?
So we have like 5 minutes left for the Q&A session. So maybe we can squeeze that session a bit and can go through the
Okay,
radiation.
so I can take 5 minutes more for my presentation, or you want to start with the question answer session? Hello.
So you can extend it for 5 more minutes, and then
Okay. Okay.
maybe
Thank
we
you.
can do the Q&A session later.
Thank you. Okay, coming on to radiation therapy, especially the head and neck radiation therapy has a role for dentists, right? So, usually it is a conformal radiation therapy for head and neck cancer. The dose is usually around 60 to 70 gray. We know that parotid and other salivary gland irreversible damage occurs beyond when the dose goes beyond 30 gray. Week-wise complications are in the first week there's nausea, vomiting. In the second week, there's mucositis and taste disturbance. By the third week, the dryness of mouth sets in, and down the road there can be multiple issues: caries, infections, osteoradionecrosis, pulp pain, necrosis, sensitivity of teeth, and trismus, right? Then there's in conformal radiation therapy, the radiation dose is sort of en bloc, and it damages whatever comes in its way. So there's another type of radiation therapy which is called IMRT, intensity modulated radiation therapy, which is available at at Shah Khanum, and it is a sort of a 3D thing in a way that it can spare the salivary gland, the pharyngeal constrictor muscle, reduce mucositis, and also sort of preserve the cochlea and the optic nerve. So radiation can cause xerostomia. You can see there is stringy saliva and lots of caries. The caries, which happens because of xerostomia in a post-irradiated patient, has a specific feature that it involves the cervical area, goes proximally, and start extending there to almost all of the teeth. So in such patients, topical fluoride application is mandatory as a daily routine. If you're not doing it, this will not stop. Class 6 caries, which are cuspal tip caries, these are very frequent in patients who have undergone irradiation. This is the usual picture we get on a bite wing radiograph. So this patient was fond of sweet tea and had this rapid radiation caries. He would take sweet tea 5 to 6 times a day, and within almost a year's time, all his teeth were lost. Usually, radiation does not cause pulpal necrosis. Initially, there is a transient sort of loss of sensibility testing, which usually comes back down the road. So your management about a patient who has had radiation therapy is a 10-minute application of sodium fluoride, CPP, SCP, topical fluoride varnish every 3 months, cellulose gel or frequent sips of water, and ice chips or saline rinses for dryness of mouth. So GC has a dry mouth gel, which is a cellulose gel, which helps in this. And then silver diamond fluoride can arrest cavitated carious lesion. You may like to treat all these in the carious teeth with GIC, RMGIC. Composite may be used if daily application of fluoride is done. I think I'll stop here because I have a lot more to show, but we don't have enough time. Thank you.
Thank you so much, sir. It was extremely insightful presentation, especially like all the information provided in here was extremely crucial for all the dentists to know, especially when we encounter such patients in our OPD on daily basis. So let's move on to Q&A session. Um, so Sana asked that does palliative therapy include lowering the cortisol level developed due to stress?
Does palliative therapy include what?
Does palliative therapy include lowering the cortisol levels which are
The,
developed due to stress?
the cortisol level. I'm
Yes.
sorry, I'm not the right person to answer this. An oncologist might be able to answer this. So ask me as a dentist. I'm a dentist.
Okay, sir. Um, And the next question by Bisma Jamil is I have heard oral cancer patients complain of burning feelings while brushing their teeth or using mouthwash. So, which toothpaste or strategy would motivate such patients to not discontinue oral hygiene measures?
So yeah, this is true because the oral cancer patients, because they do not have the right saliva. Patients who have undergone the radiation therapy, practically they do not have any saliva if most of the salivary glands are involved. So in such patients, we do want them to use, they may reduce the dose of their toothpaste that they are using. They may use the bland mouthwashes or benzidamine mouthwash or magic mouthwash, may be used frequently. And I just showed you this baking soda mouthwash. This is very bland and mild. So all these things they help in uh, sort of reducing the discomfort or the burning sensation that the patient might have during brushing or cleaning.
Okay, sir, thank you. And Dr. Paras is asking, like, is there any way to decrease dental complications caused by chemotherapy? Like, what are the preventive measures that can be
So
taken?
the preventive measures is that we want to manage all acute issues and all potential dental troubles which may flare up down the road, because when the immunity goes down, the those teeth which were in a balance with the body's defense, they flare up, right? So we have to preempt that these are the situations and these are the dental troubles which have a potential to flare up. So they should be addressed before the patient goes into any chemotherapy or any other cancer management. So there comes our role as a dentist. We should not be afraid of treating the patient. We should get, if a patient is undergoing chemotherapy, communicate with oncologist, get a fresh CBC. If the counts permit, and there's enough time for recovery for of that thing, that whatever you're doing, ask the permission from the oncologist. Go ahead and do it. Uh, so this is what needs to be done. This is why this talk is about. Is what this talk is about. That I want our general dentist to be empowered to be able to treat cancer patients.
Okay, thank you so much. And so the next question is by Rubina Shehbaz. She said that how can we manage xerostomia after radiation therapy?
So xerostomia. Sometimes some people do try pilocarpine or artificial saliva or frequent sips of water. Uh, Ice chips in the mouth, and try and keep the mouth very moist. So these are a few things. So it depends on the severity of the salivary gland damage, and like in certain situations, like in nasopharyngeal carcinoma, when radiation is done, almost all it has a massive zone of radiation. Most of the salivary glands are damaged. So it gets really frustrating and difficult because we are not able to help this patient much. But these are the few things, or you may use some glycerine droplets or dry mouth gel, which is a cellulose gel available at Humayun Dental Supply in Pakistan. So artificial saliva is usually of porcine origin, may not be used in our part of the world, but these are the few things that we have in our hand.
Okay,
And
sir.
we,
Thank
we
you.
can't
And
really manage xerostomia uh,
mhm.
to the best, right? Some xerostomia still persist even with our management.
Okay, sir. Thank you. And sir, Sana is asking, like patient undergoing radiotherapy, they mostly encounters cellulite. So what could be immediate treatment for that? Like, do you wait till for the radiotherapy to end, or
Sorry, they frequently experience what?
they frequently encounter cellulite, the the stone in the salivary glands? Cellulite.
A stone in the salivary gland, silolithiasis. So
Yes.
silolithiasis, to be honest, I have not come across silolithiasis where there is fibrosis of the salivary gland. There is irreversible damage to the architecture of the salivary gland, but I have not come across stones in the salivary gland. I don't think that's true.
Okay. And sir, Dr. Shanze Kalim asked, like after an extraction, what is the duration after which chemotherapy can be commenced? Chemotherapy or radiotherapy? Like,
A very good question. So, whenever we do an extraction, we ideally want 2 to 3 weeks of healing time. If this is not permissible, at least 10 days of healing time should be there. You want, say, initial soft tissue healing to have happened before you can commence with the next chemo cycle. So, lies on with the oncologist, try and get a 2 week window post extraction healing time, and then go ahead with the next chemo cycle.
okay, sir, thank you so much. And Spadma has asked, what about post chemotherapy? How long does a patient have to wait before they can extract their tooth, like after chemotherapy?
So, post chemotherapy depends on the extent of the myelosuppression caused by that chemotherapy. Ask the oncologist, look into the chemo cycle, how frequently the cycles are. If it's a 21-day cycle, and after about the 12th day, the counts usually start to recover in the so potent chemotherapy. So get a fresh CBC, communicate with the oncologist, do your invasive management after permission with the from the oncologist. Give a healing period of about 2 weeks or at least 10 days, and then go ahead with the next chemo cycle.
Okay, sir. And so Dr. Shanze has asked, like, if only soft tissue healing is obtained after 10 days post extraction time, wouldn't there be chance of bone necrosis, like during the chemotherapy?
So chemotherapy, the bone necrosis is more of a risk if the bone is irradiated, or if there is what you call the patient is on bisphosphonate therapy or other anti-angiogenic therapy, right?
Yes.
Whenever a patient gets a chemotherapy, it usually takes 2 to 3 days before the effect of chemo cycle sets in. So we ideally want at least 2 weeks of 14 days of healing period, and then even if the patient gets a chemo cycle, the effect of or the myelosuppression sets in about 2 to 3 days time. So this is good enough time that there shouldn't be osteonecrosis.
Okay, sir. Thank you. So there's one last question, like in patients with blood cancer who and like they don't have sufficient platelets or anything. So when they come before chemotherapy, how do you start their treatments? Like if their treatments include scaling or requires scaling or extraction. So do you avoid it then?
So if a patient has low platelet
Low
count, that is
platelet
what you
count.
are
Yes,
asking?
exactly. Yeah, like can especially can the patients with blood cancer, like
Okay, so patients with blood cancers are usually patients of lymphoma and leukemia,
yes, leukemia.
right? So in these patients, if you ask the oncologist, because these are cancers of the white blood cells, you may do your procedure under antibiotic cover. You communicate with them. You want the platelet counts to be optimal so that there is no risk of bleeding. Um, again, asking the oncologist, knowing the at which stage of the treatment you are in, at what moment, get a fresh CBC, communicate with the oncologist, may give antibiotic cover if needed, and then do your procedure. But do get you need a permission from the oncologist before you go ahead.
Okay, sir. Mm, so the next question is by Dr. Amina Sohail. Can post-wisdom tooth extraction relate to cellulithiasis?
No, not
Okay.
at all.
And the last question is, sir, what protocol you follow for bisphosphonate IV when patient came for extraction, like after having IV bisphosphonate? So is there any
Okay.
specific protocol?
Yeah, a very important question because the issue is that patients are taking bisphosphonates. I didn't show you a few cases, but a patient who is having IV bisphosphonates, especially Zometa or pemidronate, zoledronic acid or pemidronate, these are two drugs which are very potent. And bisphosphonate is a drug which stays in the bones for years and years. It doesn't wash out. So it has a half-life of many years. So the patient will always be at risk of developing osteonecrosis. And if at any point you really need to do it, you may take a bisphosphonate drug holiday of at least 3 months. Ask the oncologist to stop the drug, take an informed consent of osteonecrosis that bisphosphonate-induced osteonecrosis may set in. If the patient is on IV bisphosphonates, the risk may be from about 2-3% to 10%, right? So you get an informed consent. Ideally, this thing should be done by a maxillofacial surgeon under a hospital setting, and a primary closure should be done. Atraumatic technique should be used. Antibiotics should be used. So these are things that need to be done. Again, you need to follow this up. You want the healing to happen completely before you restart the bisphosphonate. So you want to give about uh, two months of healing period time before you again restart the therapy.
All right. Thank you so much, sir. It was an extremely insightful presentation. And we still have a lot of questions to ask, but we are out of time. And we would love to have
Sure,
another session with you because it's really
sure.
important for all the dentists.
Thank you very much.
Thank
It
you
was
for
a
your
pleasure.
time, sir. It was amazing.
Thank you so much, sir. We are very much pleased to have you. Your presentation was so insightful and informative. Thank you very much for your time and your gracious presence. I would like to request my dear audience, I have shared some research forms in the chat box. I would request you all to kindly take out some time and fill them. Thank you so much. I would like to request Dr. Hira to continue the rest of the procession of symposium. Thank you.
Assalamu alaikum everyone and welcome to today's virtual symposium on oral health awareness. I'm Dr. Hirai Sanu, Regional Director Sindh of Pride, a general dentist, your host and the chief coordinator for today's event. I graduated from Ziauddin University and I'm honored to be a part of this initiative to promote better oral health in our community. I'm currently working as a general dentist and it's my pleasure to welcome our guest speaker, Dr. Saeedullah Shah. He's a BDS Gold Medalist, FCPS, and a PhD scholar. Dr. Shah is a consultant oral and maxillofacial surgeon, assistant professor, head of department at Altamash Institute of Dental Medicine. We are privileged to have him share his knowledge and insight with us today on the topic surgical management of oral squamous carcinoma. Over to Dr. Saeedullah Shah.
Assalamu alaikum. Good evening to everyone. Today my topic is surgical management of oral cancer. Uh, So, goal of the surgical management of OCC patient to eradicate tumor with safe margin, preserve, preserve function, speech and swallowing, maintain, maintain and restore facial aesthetic, preserve local recurrence and metastasis. Patient assessment, so free operative assessment of the patient. First of all, detailed history of the patient, personal biodata, chief complaint of the patient, detailed history of the lesion, onset, duration, and progression of the lesion, medical history, cardiovascular history, respiratory history, blood disease, blood diseases, and clinical examination, extraoral examination, intraoral examination, and neck assessment. Investigation, most important biopsy to confirm the diagnosis, imaging, contrast CT, MRI, orthopentagram if the bone invasion is suspected. Pre-operative lab, CBC, RBS, LFT, anti-HCV, FB surface antigen, arrange the blood after grouping and cross matching. Chest X-ray, ECG, and GA fitness. Once the GA fitness allow for the patient should be hospitalized before procedure. Now surgical management, tumor resection, wide incision with 1 centimeter of soft tissue margin. Neck dissection, elective or therapeutic, depend upon needle status. Reconstruction, local reconstruction, regional or free flap. Aim of restoring form and function. Final uh, final histopathology defend if a tumor margin is clear to is beneficial for the oncologist. If you only radiotherapy or chemotherapy, if clear margin, maybe no need for the chemo and radiotherapy. So post-operative management of the patient, pain control, IV or oral analgesic, antibiotic, diet. Diet is very important for the OHCC patient. It should be nasogastric or effective, and proper diet should be provided to the patient. And if nutrition is available in the hospital, it should be keep on board. Dressing, regular dressing of surgical site, oral hygiene maintenance, and surgical site, again very important to prevent infection. Discharge planning and instruction for the wound care, stress exercise, and regular follow-up. Adjuvant treatment based on the marginal status and nodal spread. Refer to oncologist for chemo and radio opinion. Follow-up and prognosis. Prognosis depend on the stage, grade, and margin involved by the tumor. Early stage, 5 year survival 70 to 80%. In the late stage 3 and 4, drop to 40%. Lifelong follow-up for recurrence and metastasis in screening again important. Patient should be keep on the follow-up. Conclusion, surgical
Excuse me, sir. We are unable to hear you clearly.
Just 1 minute, please.
Sure, sir. Thank you.
Sorry. Now, this is CT of the patient involving the left cheek from upper buccogingival sulcus to lower gingival sulcus. Bone is preserved in this case. So this is the patient prepared for the surgery and neck marking. This is the neck dissection from level 1 to level 4. This is dissected lymph node. Uh, Tumor excision, wide excision is beneficial. At least 1.5 to 1 centimeter margin should be clear. This is the masseter plate, and this is reconstruction. This is the post surgical specimen biopsy. Um, the tumor size is 2.4 into 2.1 into 0.8 centimeter. Histopathology is squamous cell carcinoma, moderately poorly differentiated. Depth of the invasion of this tumor is 0.1 centimeter. Lymphovascular invasion not identified. Perineural invasion not identified. So margin anterior margin 0.5 centimeter away from the tumor, posterior margin 1.5 centimeter. Again surgical, the anterior margin 0.5, posterior margin 1.5, superior margin 0.3 centimeter, inferior margin 0.3 centimeter, and deep margin 0.7 centimeter. Dissected lymph node. Total lymph node in level 1 is 2. Only one lymph node is involved by the tumor. Size of the largest lymph node 0.4 into 0.3 centimeter. Level 2 lymph node. Total number of lymph node recover 7. Involved by the tumor 1 lymph node, and size of the largest lymph node is 0.5 into 0.4 centimeter. Level 2A lymph node. Total number of lymph node recover 12. Only one lymph node is involved. Size of the largest lymph node 0.2 into 0.1 centimeter. Level 3 lymph node, 11 lymph node is recovered, and there is no involved by the tumor. Histopathological TLM staging PT2 and N2B. This is the post-operative picture of the patient. This patient developed uh, salivary fistula, and we give just a neck incision to drain the saliva. And this is the post-operative picture of the patient, and this is the post-operative CT scan. Again, post-operative CT scan of this patient. Now, this is the case 2. This patient presented with a huge tumor involved the buccal mucosa and temporotemporal erosion of the mandible and some extension toward the infratemporal fossa. This is again CT scan of the patient, and this is OPG of the patient having floating teeth, third molar. This is the pre-operative picture of the neck dissection. This is intraoperative neck dissection. This is a resected tumor. This is the intraoperative picture of resected tumor. Uh, Resected tumor with buccal mucosa, hemimandibulectomy, and partial maxillectomy. This is the reconstruction, and this patient is reconstructed again with the masseter muscle to reconstruct the maxilla and the cheek. This is again the post-operative picture of the patient, and this is the intraoperative picture, intraoral picture. Now, histopathology. mucosal margin, anterior lingual margin 2.1 centimeter away from the margin, and posterior lingual margin 0.6 centimeter away, and inferior lingual margin 2 centimeter away, inferior lateral margin 2 centimeter away, and interior buccal margin 0.7 centimeter away. Bone margin, interior margin 2 centimeter, posterior margin 4 centimeter, and interior maxillary bone resection 1.8 centimeter away, posterior maxillary bone resection 1 centimeter away. Lymph node, dissected lymph node, level 1A, total number of lymph node 14, and involved by the tumor 4. 4 nodes are involved by the tumor. The largest metastatic lymph node 0.9 to 0.8 centimeter extranodal extension is present. Level 2 lymph node, total number of lymph node 0. Level 3 lymph node, 1 lymph node is recovered and tumor free. In level 4, total number of lymph node recovered 6 and tumor free. In level 5, total number of lymph node recovered 3 and again tumor free. Histopathology, TNM classification, PT4A and N3B. Now this is the case 3. This is a young man presented with the squamous cell carcinoma of the lower lip and right cheek. This is the pre-operative CT scan of the patient. This is intraoperative neck dissection. This is a resected tumor, and this is reconstruction. In reconstruction with the local advancement flap. Post-surgical biopsy, tumor size 4.2 into 2 centimeter, histopathological type, keratinizing squamous cell carcinoma, grade 1 well differentiated, depth of the invasion 0.8 centimeter, surgical margin, superior mucosal margin, resected margin 0.3 centimeter away, inferior mucosal margin 0.3 centimeter away, lower lip mucosal margin 0.7 centimeter, and lower lip skin margin 0.7 centimeter. Dissected lymph node, level 1A lymph node, total number of lymph node 5, and all are tumor free. Level 1B lymph node, total number of lymph node 6, and all are tumor free. Level 2 lymph node, 8 lymph node are recovered and tumor free. Level 3, 12 lymph node are recovered and all are tumor free. For this case, TNM classification PT3 and N4. And this is post-surgical CT scan of the patient. And this is the post-pic of the patient after radiotherapy. This is one of the most important thing if intraoperative large lymph node are present. So one of the best maneuver to decompress the metastatic lymph node to excavate intraluminal fluid. There are two things are important when you just withdraw the fluid. The first thing, if it ruptured, it not surgical field is not contaminated with the lymphatic fluid. Secondly, it compress the vital structure. If you decompress, it easily dissected from the underlying internal jugular and internal carotid artery. And this is one of important structure, right major lymphatic duct. On the left side, there is thoracic duct. If this duct is damaged, the post-operative patient presented with Kyle fistula. Thank you.
Thank you very much, sir. Thank you for your gracious presence. Thank you for an insightful, informative presentation. Now, sir, our dear audience have a few questions for you. Sir, Dr.
Yes.
Amir, thank you. So Dr. Amir Meher is asking, if a patient comes with limited mouth opening, how biopsy will be performed?
If depend upon is if you clinically visible the lesion, you can do in the local anesthesia and general anesthesia. और अगर लिमिटेड है पोस्टीरियरली है और ब्लीडिंग रिस्क है तो दिन बेटर टू डू इन जनरल एनेस्थीसिया. अगर इंटीरियरली कमर्शियल एरिया पे है, अगर आप इजीली ब्लीडिंग को मैनेज कर सकते हैं then you can do in the local anesthesia.
All right, Sai, thank you very much. There is another question. Could you elaborate on the most effective ways to differentiate between potentially malignant disorders and early stage oral cancers clinically?
Clinically, yes, if homogeneous lesion, for example, leukoplakia, homogeneous leukoplakia, and first of all, most important thing is history of the patient. If within 1 to 2 week homogeneous and there is no history of chewing tobacco, smoking, uh, is mostly it just give instruction to the patient and medication. If there is it increase in size and change in the color, then go for the biopsy to confirm the diagnosis.
All right, sir. Thank you very much for the elaborative answer. Sir, we have another question. What are the current trends in the reconstructive surgery after tumor resection?
Yes, again, this is a very important question. Uh, best to do the free play for radial forearm and prefibula flap for the bone reconstruction, but it depend upon the uh, patient status, affordability, and medical history. Most of the patients presented unaffordable. If you do a major surgery, the patient can't afford even it not afford the medicine. It is very difficult for the patient to be to a large means resection and keep the patient in the ICU and a burden for the patient. So it's again depend upon the patient affordability, stage of the tumor, and again patient's health of the patient.
Sir, we have another question. What is the most proper treatment for limited mouth opening?
So in OSCC or oral submucous fibrosis.
I think, sir, it is related to oral submucous fibrosis.
Yes. In OECG, if for stage 1 and 2, just give the instruction and oral medication and intraregion injection of steroid, placental extraction, and exercise and cessation of the habit can improve the mouth opening. If it present in the late stage 4, it's a surgical management. In the surgical management, you do fibrotomy, extraction of the wisdom teeth, and if enlarged coronoid, then do for the coronectomy and reconstruction. Reconstruction with the buccal fat and nasolabial flap. In the buccal fat again is lead to the fibrosis. If you do the nasolabial flap, it give best result.
Thank you very much, sir. Sorry, another question. How important is the role of a multidisciplinary team in oral submucous squamous carcinoma treatment planning? And what does the follow-up protocol look like after surgical treatment?
Yes, actually, oral squamous cell carcinoma is a multidisciplinary team approach. It can't do by a single surgeon or a histopathologist or oncologist. It's a team approach. It involves a radiologist, histopathologist, surgeon, anesthetic, oncologist, nutritionist, and sometimes you can need general surgeon for the fig tube, ENT for the tracheostomy. Is a lot of consultant involved. Actually is a team approach. And follow up for the post operative follow up again is very important. You in the early follow up you can follow up even in the post operative early. Every dressing I'm doing I do by self is have a very good result. If you refer a patient for the some technician to do the dressing, most of the patient come back with me infection. The follow up again is very important. You see the patient even every 2 to 3 days in early, then after weekly, and after a month and 3 months and 6 months follow up again is very important.
Thank you very much, sir. Sir, I don't know if it's a question or maybe a statement that Dr. Saima Manzoor is saying lymph node decompression is documented maneuver. Sir, please kindly comment on this. Excuse me, sir. Well, all right, sir. There is another question. Is there artificial bone to reconstruction of jaw? Sir Said, are you here? Well, I don't know. I think there is. Thank you very much, sir, for your insightful and informative session. We are truly grateful to have you on board. I think sir might have left. Thank you, sir, and thank you, dear audience, for the question answer session. I think we should proceed to our next speaker, which is Dr. Mariam Fazal. Meanwhile, I would like the audience to kindly fill the research forms and feedback forms provided in the chat box. So we have on board Dr. Mariam Fazal. Let me introduce her to all of you. Assalamu alaikum everyone. I'm Dr. Samad Sultan, Assistant Director at PIDE, and I'm pleased to introduce Dr. Mariam Fazal, graduate of ISRA Dental College, where she earned her Bachelor of Dental Surgery BDS in 2019. She completed her house job at her alma mater during 2020 and 2021, where she discovered her passion for oral and maxillofacial surgery. Driven by her dedication and focus, Dr. Mariam Fazal cleared the FCPS Part 1 examination on her first attempt. She subsequently began her post-fellowship training at one of Karachi's most prestigious institutions, Jinnah Postgraduate Medical Center, under the guidance of esteemed Dr. Jahan Alam. Currently a third-year resident in oral and maxillofacial surgery, Dr. Mariam Fazal had recently passed her intermediate module on her first attempt as well. Alongside her residency, she also extends her expertise to patients at a private clinic in Karachi, continuing to build a promising and impactful career in her field. We are honored to have you with us today. Dr. Mariam Fazal, I now invite you to share your insights with us. Over to you, ma'am. Dr. Mariam, you are not audible. Can you please just check if your mic is unmute or not?
Hello everyone, Assalamu alaikum. Am I audible? Hello, Dr. Saman, am I audible?
Dr. Mariam, you are not audible. Kindly, if you can just adjust your mic.
Hello, Dr. Saman, am I audible now?
Little bit, ma'am. Kindly make some more adjustments with your mic. आप थोड़े audible है, but आपकी आवाज थोड़ी कम आ रही है, मैम. मतलब volume थोड़ा low है.
Hello, Dr. Saman, am I audible now?
Yes, ma'am, you are audible, but आपका volume थोड़ा सा कम है. अगर आपका हो सकता है तो ठीक है. Otherwise, you're audible.
Hello,
You are
Dr.
very
Saman,
clear.
am I audible now?
Yes, ma'am, you're audible. You're very clear. You're audible.
Hello, am I audible now?
Yes, ma'am, you're audible.
Okay, I think I'm audible now, I'm assuming. Assalamu alaikum everyone, this is Dr. Mariam Fazal. a postgraduate trainee in the Oral and Maxillofacial Department, and the topic for my discussion today is Guide for Oral Cancer Screening and its Early Detection. Because early action can save lives. So, I will walk you through my contents today: introduction, epidemiology, signs and symptoms, step by step clinical screening approach, and a brief case review. So, for the introduction, as we all know, that oral cancer is a common cancer of a global concern. It is a potentially life-threatening condition that can occur in any part of the oral cavity. But early detection through effective screening can improve outcomes, reducing mortality and morbidity. As we all should understand why there should be focus on the oral cancer. We, as a matter of fact and understanding, oral cancer early detection can save lives. Because as you all have seen in your clinical practices, that oral cancer often goes unnoticed in early stages. But if it is presented to you in early stages, this can improve the survival rate significantly and it can have a better outcome. We can have a high mortality rate because despite it being a preventable and a treatable oral cancer disease, but it as it is not discovered early, it has a higher mortality rate. Now we should talk about increasing incidence. As you all know that there are risk factors for the oral cancer development, like tobacco, alcohol, that we will be briefly discussing in the next slides. But due to all that, we have an increasing incidence. As we all know again that oral cancer can hugely impact your quality of life. People can present to you with difficulty in eating, speaking, and socializing. But the good thing about is that oral cancer is preventable. But how? We can have the lack of awareness due to which its preventability is reduced. Now I shall be taking you towards the epidemiology. The oral cancer is the sixth most cancer worldwide, most common cancer worldwide. About 3,77,000 cases are globally diagnosed each year. Its mortality rate is unfortunately half the span, that 1,77,000 people and patients annually occur often encounters death worldwide. The 5-year survival rate ranges from 50 to 60%, but it can be much lower in low resource settings due to the late diagnosis. I shall walk you through the risk factors. We all encounter patients having risk factors of the oral cancers. When it is timely diagnosed or prevented, we can have a patient's better outcome. We have non-modifiable risk factors and modifiable risk factors. The non-modifiable risk factors are the age, gender, socioeconomic status, and the family history, whereas the modifiable risk factors, which are smoking, alcohol consumption, bitternut quid, chewing, tobacco, your diet and nutrition plays an effective role as well. Your lifestyle, your poor oral hygiene, ultraviolet rays exposure, and human papillomavirus infection. These are all the modifiable risk factors. But if they are not taken care of, your oral squamous cell carcinoma progresses. We, as dental practitioners, residents, and basically dentists, have already coming patients to us in OPDs with warning signs, but they are often overlooked due to their clinical resemblance to minor infections and dental problems. I shall take you through the key signs that you should all notice while seeing any patient presenting to you in your OPD. That any patient who has presented to you with a persistent ulcers that is not healed in 2 weeks, a patient presenting to you with a presentation of white or a red patch in the mouth, any lump or thickening in the cheek, patient presenting to you with the difficulty in chewing or swallowing or speaking, or any persistent sore throat, ear pain, numbness of the tongue, pain in the jaw, these are all the significant signs that should never be overlooked and should always be noticed. I have added a flowchart for you to have a better understanding on how we can have an idea to treat the patient of squamous cell carcinoma, or basically any patient who is presenting to you with the oral lesion in your OPD. Any patient who is presenting to you in the OPD with oral lesion, always associate its previous clinical history and data of the patient and give the relevant treatment. You are fortunate enough if the patient is being presenting to you with a resolvement of that specific lesion with your local treatment, then keep the patient for follow-up. But unfortunately, if on follow-up, if you notice any patient who is presenting to you or telling you about the changes has a persistent or a progressive nature of the lesion, then that specific lesion is classified as a suspicious lesion and should immediately be counseled for a biopsy. On biopsy only, you can have a histological identification and you can better treat the patient on their specific treatment plan and diagnosis. I have added a slide for you to understand about the precancerous and the pre-malignant lesions. So, as a matter of understanding, we should all understand basically what a precancerous lesion. So, pre-malignant lesion is a morphologically altered specific tissue in your oral cavity. That specific tissue will have a greater chance of malignancy than the normal tissue, as if a white or a red lesion in leukoplakia or erythroplakia or a lesion of the reverse smoker or actinic keratosis, this patient will come to you with a patch in their oral cavity. And that specific lesion will have more tendency to convert into a malignancy. Whereas if you talk about precancerous condition, we have a condition like oral submucous fibrosis, epidermolysis bullosa, desquioid lupus erythematosus. These conditions are basically the generalized state in your oral cavity. And these generalized state of the oral cavity can happen to have the cancer in any part of this oral cavity, any site of the oral cavity. Okay, so I will take you through the step-by-step clinical screening approach. First of all, you all need to understand what are the approaches to have the diagnosis for it. So, patient's complete history is very important. Visual screening examination is the second step. Then we have the optional adjunct tools, and then we have the diagnostic biopsy. The step number one, which is patient's history, it plays an immense important role in the diagnosis. If your patient presenting to you with any suspicious lesion, always associate with the habits that the patient have. If the patient has tobacco, alcohol, areca nut use, please understand it. Then if the patient presenting to you with the symptoms such as pain, ulcer, trauma, irritation, has a family or a personal history of cancer previously, and is vaccinated or not vaccinated for human papilloma virus, this all should be associated because these histories are the high risk and should always be prioritized for frequent screening. Then comes the second step, which is your visual and the physical examination. It basically tells you about the comprehensive intraoral and the extraoral inspection of the oral cavity. By intraoral, what you need to understand is that your lips, your buccal mucosa, your gingiva, your surfaces of the tongue as a whole, your dorsal, your lateral, your ventral surface of the tongue should all be inspected. Your floor of the mouth, palate, tonsils, oropharynx, these are all the suspicious sites that should be properly screened and should be properly inspected. Then comes your palpation for your lymphadenopathy. That is cervical lymphadenopathy. These all the steps that I have discussed is a skill dependent, but they are essential for your routine investigations and your routine screening. This is the pictorial images that I have added for you to have a better understanding about your examination as a whole for your oral squamous cell carcinoma. In the first image, you can understand that this is showing the cervical lymphadenopathy examination. Then for the lips, for the labial mucosa, you can invert the lip and have an investigation and have an inspection. Then for the buccal mucosa, your floor of the mouth, this image is showing you the tongue, the floor of the tongue, and then as a whole, this is how your proper inspection and palpation for the oral cavity should be done. Okay, then we have step 3, which is your optional screening adjuncts. These adjuncts basically can enhance your detection, especially in the borderline lesions. First of all, we have this toluidine blue staining. So basically, I have added a pictorial for you to understand as well. This toluidine blue staining, in which we add a toluidine dye in the suspected lesion, in the suspected area, and wherever that, and then we basically rinse it with your acetic acid solution. After that, it shows you the retention. If the dye is retained there, that means that that area is positive, has a positive result, and has a darkly stained area and has a dysplastic changes. Whereas if after your wash with acetic acid, if the dye is not retained, that means that shows a negative result and has a normal tissue. Then as a second adjunct, we have a chemiluminescence, VisiLight, and autofluorescence devices, that is Wellscope. So basically, this is a handheld device in which we emit a light out of it. It's a blue light that is emit into the suspected lesion. And wherever there is a changes in the oral mucosa, the oral surfaces, that specific light will be darkly stained there. As you can see in the image showing you that the abnormal epithelial cell is darkly stained in the image. It is a non-invasive technique. But for your understanding, I just want to add to clarify that these all your adjuncts are not your diagnostic tools and they're not a replacement for biopsy and should always be used as the screening measures. Then also comes your brush biopsy. In brush biopsy, you can see that it's a transepithelial sample for cytological evaluation. Then comes your last adjunct, that is salivary biomarkers. You know that saliva is a biofluid that is available in every patient. And that saliva has proteins, interleukins, and your cytokeratin fragments. And that shows promising results in the research. And this is all as well a non-invasive mass screening technique. Okay, after all these screening measures, then comes the diagnostic biopsy. So for the biopsy, you should always be understanding that any suspicious lesion that has not resulted or that has not that has not responded to your local treatment, there should be, and as persisting for 2 weeks, should always be biopsied. And what are the types of the biopsy? That depends on your size of the lesion and your site of the lesion. If the size of the lesion is large, it should always go for incisional biopsy. And if the size of the lesion is small and a complete removal is possible, always go for excisional biopsy. Fine needle aspiration cytology is done in cases of lymph node involvement. As we have already discussed, that biopsy is the gold standard for diagnosis. Okay. Then we have to discuss the role of the imaging modalities for your screening. As you all know that your imaging is crucial for staging, follow-up, and deep lesion visualization. We have a role for conventional imaging, where we do the panoramic radiographs to see the bone loss, impacted teeth, ultrasounds. We have also the role for the advanced imaging that includes your CT scan, MRI, and your PET-CT. For CT scan, you can see the bone erosion and the nodal involvement, whereas MRI, if your soft tissue is involved, you take the MRI, and PET-CT is used in the cases where metastasis is noted. After all these previously discussed adjuncts, if the patient is diagnosed and investigated for squamous cell carcinoma, there comes a role for the TNM staging. We stage the patient. TNM staging has been discussed previously very nicely. So I want you to just understand that we stage the patient according to their tumor size, node involvement, and the metastasis, and that specifically guides for you to have the treatment strategy. Okay, so now we should understand the survival rate by stage. Fortunately, if any patient who is staged at stage 1 or 2, which is the early stage of the squamous cell carcinoma, has a great outcome. The 5-year survival rate is amazing, which is around 8 to 90%. And unfortunately, any patient who comes in the later stages, which is stage 3 and 4, has a poor prognosis, which is around less than 40% in 5 years. Okay, now we should all understand that how can we prevent the squamous cell carcinoma. We should all design the prevention strategies. As a dental practitioners, maxillofacial residents, we should all always be doing the primary prevention. How we can do that? We can always aware the patient about the tobacco and the betel nut and the alcohol and their possible consequences, and should always have a guide for them to sedate and counsel them. Human papilloma virus vaccination should always be promoted. There should be a proper campaigns in which oral hygiene is instructed, and patients, even the general population, should always be guided for the diet rich in antioxidants. As a matter of secondary prevention, any patients or any person who is suspected to have oral squamous cell carcinoma should be screened every 6 to 12 months, and there we should always have opportunistic screening all in clinical encounters and mobile units in rural areas. As a tertiary prevention, any patient who have had gone through oral cell squamous cell carcinoma and has gone through surgery, we should have a rehabilitation post-surgery centers. We should have a support groups where the quality of life interventions are discussed, and we should have as a regular surveillance for recurrence. Okay, so for you to understand what are basically the barriers to early detection. As we all know that in our general population, there is a lack of awareness among the patients and general practitioners. We have a poor access to care in rural regions. We have cultural taboos and fears, which bring the patient to ignore their clinical signs and symptoms. We have inadequate training in visual screening, and we have financial constraints. And I'm sure, pretty much sure, all of us must have encountered patients coming to us with ulcerative squamoproliferative lesions, but are not ready for having a biopsy done because there are cultural taboos and fears among them. And now we will discuss what are the benefits of the early detection. Obviously, as the cancer is early detected, the patient will have a less aggressive treatment, will always have a better functional outcome, will have a reduced psychological burden, and will improve their quality of life. Okay, with that, I want you all to have a view on a case history that has been done in my own institute, parent institute. And for your understanding, I want to bring this point into your acknowledgement that all this history and the patient pictures are shared with their consent. So we have had a 65-year-old male patient, Mohammed Sharif. He came to our OPD with an ulcerative lesion on their lower lip. So after investigations, after looking at the patient, I will show you the picture. This is the picture. So this patient had a ulcerative, proliferative, and exophatic growth on the lip, extending from the center midline of the lip to the ask the patient and counsel the patient about biopsy. The patient was ready and we did the biopsy. And after biopsy, this patient was, after this is the clinical image I'm showing you in all the planes. So we counsel the patient and their family about their biopsy and how this patient can have a life. So the biopsy was done, which was revealed as moderately differentiated squamous cell carcinoma of the lip. Then we went for a CT scan of head and neck with contrast. Luckily, this patient had a tumor size of 3.5 into 2.2 centimeter in greatest dimension, and this patient had no bony involvement. Subsequently, no any measurable cervical lymphadenopathy. After this evaluation, the histopathological evaluation, the radiographical evaluation, the patient was staged as stage 2, and we counseled the patient for their surgery. After all the relevant investigations, the patient's plan for surgery was done, in which we planned the patient for a primary removal, wide local excision of the lesion, and a primary closure of the lesion, as the defect intraoperatively was not very huge. I will show you the next image. This is the intraoperative picture in which the excision along the mark outline was done. The primary, this is the defect. A V-shaped defect was left after the wide local excision of the tumor. We did not need any flap for the reconstruction, as the approximation of the defect could be done with the primary closure. Okay, I think the picture is not in. We did the primary closure, and the patient was shifted uh, to the ward with widely stable, and all the post-operative care was taken in the ward. Patient was retained until discharge. The histopathological report also showed the great result. Sadly, this surgery has been done in 2021, but sadly, I do not have his recent post-op pictures, but the patient did come to ward in around a weeks before, and I did not manage to take the pictures, but the patient was doing great. He was very thankful for his surgery and for his life support. But the main thing that the patient was timely managed. The patient came to us timely and was managed timely. So, as a conclusion, I want you all to understand that oral cancer is life threatening, but it's preventable, highly treatable if detected early. So, after a structured clinical approach, starting with patient history, visual inspection, and adjunctive tools and timely biopsy, it can significantly reduce the mortality. I want you all to have a take-home message that a 2-minute visual screening can save a life. Let's make it a routine. Thank you, everyone, for your patience, and I hope I could bring some insights to your topic.
Thank you very much, Dr. Mariam. It was such an insightful and informative session. Your presentation was so well made. Everybody is appreciating it. We have a few questions for you, ma'am.
Yes, sure.
Ma'am, one of the question is, how often should individuals undergo oral cancer screening?
Yeah, that's an amazing question. Uh, Definitely, patient who is having a risk factor for oral squamous cell carcinoma. I have discussed your risk factors. The patient that specific patients and a group of patients should be screened. But as a matter of fact, your patient's history plays a vital role. If there is no any vital history of your habits, the age, the socioeconomic status, even if the patient has a human papillomavirus vaccination done, so there is no need for oral screening in that specific group of patients. But the patients having a history and the risk factors about it, that specific group of patients definitely need a screening. And sadly, I did not see any institute in my knowledge, I have not seen any institute doing the oral screening. But if it is done anywhere and it's made a practice, I'll highly appreciate it, because it's really a non-invasive procedure and this does not cause any harm to the patient for the long run.
Thank you so much, ma'am, for the elaborative answer. There is another question. What lifestyle factors contribute to the development of oral cancer?
Yeah, that's one amazing question as well. So with lifestyle, I want you all to understand that we people tend not to have a diet full of antioxidants. Your patients should, your normal generation, we all should have a diet which in which entire are taken, consumed proper, and as well as you should always take this into notice that your habits of having the alcohol consumption, orbital nerd, because these things you must have seen, these are very ineffective in cost. So everyone just out of a habit takes it, despite of not knowing the consequences these are being taken. But if with proper campaigns and proper awareness, these habits can be cessated, and then only we can have a patient and a lifestyle approach, a saving lifestyle approach.
Thank you so much, ma'am. Yes, absolutely, you're right. Okay, we really need to cut down our um, illiterate kind of habits which add no meaning to our life, no benefit to our lifestyle. The last question is there, ma'am. How can public awareness campaigns help reduce the incidence of oral cancer?
How can? Yeah, that's an amazing question. Basically, okay, fine. We have always talked about our rural areas population to have more have inaccessible knowledge about it. But have you seen our elite class people doing the same things as our rural areas people doing? Yes, you must have seen that. In my own practice, I am seeing people with elite class having a proper information and having a proper access to internet. They even consume the same amount of drugs, same amount of alcohol, same amount of areca nut, and same amount of tobacco, just as a fun maybe, and just maybe out of that courtesy one friend is doing, if I should not be doing, I may be just odd one out. Just people have that fear of not being odd one out, people consume this all. So if we frequently do these campaigns, and by frequent I mean that I am a medical official resident, I should start it from my own home, I should start it from patient to patient, that I see
Yes, ma'am.
still knowledge about what consequences can happen in while taking these things may give us a better outcomes and results.
All right, ma'am. Thank you very much. Your presentation was so good. It was so insightful, very informative. Everybody is appreciating it. Ma'am, last question is there. Why is oral cancer painless during early stage?
Yeah, that's a great question, and I would really want you to all understand. So basically, oral cancer in early stages is painless.
Yes, ma'am. All right, ma'am. Um, I think there is a little um, disconnectivity, but thank you very, very much, ma'am, for your insightful and informative session. We are very much grateful for your gracious presence. Thank you very much once again. Um, Jazakallah, ma'am, for being there, and thank you very much, audience, for a wonderful question answer session. Over to Dr. Farouk, who will be continuing with the rest of the symposium. Thank you.
Assalamu alaikum, guys. I hope you are doing fine and I'm audible to you. Am I audible, Dr. Saman?
Yes, sir, you're audible, and welcome, sir.
Thank you very much. Okay, so guys, my name is Dr. Mohammad Farooq, as you all know, and I'm the founder and director of Pride. So I would like to start today's session, basically today's last lecture of this symposium. So, ladies and gentlemen, it is our honor to welcome today's esteemed speaker, Dr. Mustafa Anwar Chaudhary, a highly accomplished dental professional with decade-long dedication to excellence in clinical dentistry and education. Dr. Mustafa earned his BDS degree from University of Karachi in 2011, and further he his credentials by achieving the MHDF from prestigious Royal College of Surgeons, England in 2013. He has since been actively involved in both clinical practices and academia. He currently serves as a registrar in Operative Dentistry Department at University College of Dentistry, the University of Lahore, a role he has held since 2015. In addition to his academic responsibilities, he is also the principal dentist and advanced restorative dentist at Dental Suite, where he has been leading since 2021. With a strong clinical background and a passion for advancing dental knowledge, Dr. Mustafa brings a wealth of experience to today's session. Practicing dentistry since 2011, he has continually demonstrated commitment to patient care and professional growth. Today, he will be presenting a highly insightful and clinically relevant topic titled Oral Cancer Diagnosis by a General Dentist, a Case Report. This presentation promises to highlight the critical role the general dentist can play in the early detection and management of life-threatening conditions. Please join me in warmly welcoming Dr. Mujtaba Chaudhary. Assalamu alaikum, sir. Over to you.
Welcome, sir.
Walaikum salam, everyone. Thank you for a very elaborative introduction and nice seminar all the way along. I think I am the last speaker of this session. Can you guys audible?
Yes, sir, you are audible.
So my screen is, everybody can see my screen?
No, sir, your screen is not visible, but you are audible. You are very clear.
So you,
No, sir, your screen is not visible yet.
but I did it from here, but sure, okay, this is.
Sir, now it's
Yeah.
visible. Yes, sir.
Yeah. Okay. My topic of presentation is oral cancer diagnosis by a general dentist. This is a case report actually. And now I formally start the presentation. My brief introduction was done by the doctor. Now, this is the actually behind every case of any advanced oral cancer, there is a missed opportunity for the early detection. And I read it somewhere, so I quoted it over here. And I think this is the best we can do as a general dentist or as a specialist, that we can detect the cancer in the early stages as early as possible. So first of all, I start with the incidence. The oral squamous cell carcinoma actually accounts for about 90% of all malignant neoplasms of the oral cavity. And globally, oral cancer, including the oral squamous cell oral cavity, ranks the 16th most common malignancy with an incidence of about 350,000 new cases annually. So this is a very big amount, and it is the 16th most common malignancy all over the world. So it's our basic and the more vital duty for diagnosing the oral cancer or all the neoplasms of the oral cavity as early as possible. What about the survival rate? The 5-year survival rate is almost below the 40% for diagnosis made at stage 3 and stage 4. But it reaches to 80% when the cancer is detected at an early stages, that is stage 1 and 2. So this is the very very huge difference in both of them. The 80% and the 40%, when there is a stage 1 and 2 and the stage 3 and 4 now, so it's the treatment of early stage oral cancer patients also suggest a better prognosis. Also, the new diagnoses, which are 70% at a late stage, which also emphasizes the critical need for early detection and prevention strategies. So now what about the early diagnosis? It is also crucial to improve survival of the patient, to determine patient's prognosis, therapeutic path, which we have to follow. We have to follow after the diagnosis, and to reduce the mortality. And also early detection often leads to better treatment outcomes, not having to resort to invasive surgical therapies. So for the patients, better treatment outcomes and also the invasive surgical therapies, we have to diagnose as early as possible. And what about the clinical errors which we made in the diagnostic criteria? There are obviously there are a lot of errors we made as a clinician. There are many which occur during the diagnosis of oral squamous cell carcinoma, also with the pre-neoplastic or neoplastic conditions, also with the resultant devastating. It's also consequences are very devastating. It's both for the patient in terms of health and for professionals in terms of medical legal responsibility. Actually, as a professional, we have in the global village, the medical legal responsibility is very high. In our country, you can say there are less practice of these medical legal things, but in the other world, there's many medical legal responsibilities happen on the dental professionals. Now, what is the medical legal aspects of the delayed diagnosis? So it is also important that we have to analyze for the preventive, for the interceptive or the diagnostic strategies. We have to diagnose the oral cancer as early as possible, because the legal implications of the clinical evaluation errors and diagnostic omissions, which are all very important, and the type of medical damage produced and the professional liability. Actually, we have a professional liability for the patient. We have to diagnose the patient. We have to diagnose the patient and send it to the specialist or to the oral maxillofacial surgery department. So the legal implications associated with delayed diagnosis or misassessment of oral carcinoma is essential to understand, because the challenges and the responsibilities in both medical and legal fields are very important. Now, the most common mucosal sign and symptoms which we can see in the patient's mouth is actually we have to recognize the range of signs and symptoms. Generally, the most common mucosal signs and symptoms are persistent ulcerative lesions which are present for more than 2 weeks, persistent white or red patch or a plaque. It may be a white colored plaque or a red colored or a mixed white and red, and nodule or swelling, any nodule or swelling in the oral cavity or the buccal region or somewhere in the mouth, and the localized area of bleeding. If there is a persistent bleeding in any area or somewhere in the oral cavity. So these are a few most common mucosal signs and symptoms which we have to be very careful in diagnosing any patient which came to our clinic or for the diagnosis. Now, it's our core responsibility for the referral to the specialist by the general dentist. Actually, any suspicious lesion which is presumed trauma ulcers that do not improve or persist for more than 2 weeks after the removal of potential local irritants. The local irritants may be whatever it may be the smoke, it may be the betel nut, it may be the denture, it may be something else. So any potential local irritants, we have to removal of that and should refer these cases to a specialist for further evaluation. Now I will move forward to the case presentation. Actually, the patient referred to me by my old patient, and the patient came from somewhere else. It was he was going to some other dentist for 6 months, and the other dentist diagnosed him wrongly for the oral candidiasis. So this case actually hits me that and that dentist was very senior dentist in the town, but he misdiagnosed, misassessed the patient, and was treating him for that for oral candidiasis. Now move forward. Consent was taken for the obtained patient regarding the publishing his data and photographs. Now the history. The case involves a 72 years old man who was the non-smoker and in a good general health, having positive diabetes mellitus, having hypertensive and the uric acid complications, but he complained of an enlarged fungating buccal mucosal lesion. This is very important. We have to mention that enlarged fungating buccal mucosal lesion at the right mandibular posterior region in the buccal vestibule. So it was actually persistent for at least 6 months because the other dentist was treating him for other disease, that is oral candidiasis, and he was just giving him the gels and oral solutions, nothing more than that. So next, we move forward to the history of the presenting complaint. Actually, the patient was a denture wearer since 6 years, and he made the new denture 1.5 years back. That was actually the poorly fitted. The new denture was poorly fitted, so it was irritating her mucosa, the buccal mucosa, and but the patient was wearing that denture because you don't have any other option to eat and to do social life. So he was taking the treatment for oral candidiasis for more than 6 months. Now move forward to the oral examination, a hard, non-tender red mass characterized by an ulcerated surface. It was when I checked first time, it was the hard, very non-tender, it was red mass, and it was characterized by an ulcerated surface. And it was adherent to buccal mucosa, specifically in the buccal vestibule and involving the buccal side of mandible only. And I checked the other side. Other side was a little patchy, but not eroded or something like that. So it was unilateral. It was on the one side, right side of the mandible. So the type and localization of the oral lesion, the lesion didn't bleed upon palpation. I checked it. It was actually a little tender from uh, on a specific one point. Otherwise, it was all non-tender. So no palpable locoregional lymphadenopathy. I checked it by myself on the chair side in the first visit. This is clinical presented to me. I took the pictures and I showed it to the patient, and it was also taken for my records. And it was you can clearly see that apprehend that this is the buccal mucosa is very fungative, and rolled margins were there. And next, this is other side of the picture. See, there is some. You can see there is some ulcerative region also. Some white patchy appearance of the buccal mucosa. This is another view of the patient in the same visit. This is the close picture of the. Now I recalled him after a week, and in the second visit, the patient reported increasing discomfort and pain. So I planned the biopsy in the third visit after the thorough evaluation. This is in the second visit I took again. Again I took the pictures. Now this is very much clear. The biopsy examination was done after a week. Request was sent to the histopathological lab. I wrote the letter on my letterhead, prescription pad, and sent it to the lab. So it was requested to do the biopsy examination of the sample. This is the biopsy report. It came with my fears that it is the squamous cell carcinoma, well to moderately differentiated, and was atypical squamous cell carcinoma. This is the biopsy procedure. I did it myself. I cut the portion almost 10 into 20 size excisional biopsy. I did that, and I sutured it after that in the local anesthesia. Now, when biopsy report came, I wrote the referral letter to the maxillofacial surgeon. Actually, I sent it to the Shaukat Khan Memorial Cancer Hospital, and I wrote the letter, referral letter for the maxillofacial surgeon and for the surgery department for staging and surgical treatment. Now, the oncologist sent the patient to the CT head and neck, was advised by the oncologist for grading and staging of the oral squamous cell carcinoma. Then CT head and neck report was confirmed that no bone involvement and metastasis and any erosive lesion underlying structures was confirmed. So no significant lymphadenopathy. It was all in the tissue. And by the oral maxillofacial surgeon, the excision of pride buccal mucosal ulcer in the oral cavity. Also, the neck dissection was planned. Then, second stage surgery was done after a month of the first surgery under LA. This is on the chair side. The primary side, so complete removal, complete excision of the carcinoma at the primary side, and also oral surgeon performed the prophylactic neck dissection and block, means in one continuous specimen, the defect in the mouth reconstructed with palatal graft. The patient opts for this treatment plan, and he makes a very good recovery following surgery. But he has a difficulty in eating and swallowing, and also in drinking water. So he has to use the straw and all that. Because there you can see the post-operative picture, the sutures of the second stage surgery, which is still present after 2 weeks. Now, this is the post-surgical excision of right buccal mucosa was performed. Defect was reconstructed using a palatal graft and the partial sliding local flaps. So it was all done. It was very rigid because the connective tissue was not there. Very hard. I palpated it by myself, and but the patient was recovering in a very good manner. This is a post-surgical condition situation. You can see the scar on his face, and there actually the mouth opening is not that good because it's only the 2-finger breadth. Actually, because the connective tissue is absent, so musculature is not that good on the right side. This is the neck scarring, and here it is. So this is the open neck dissection was performed by the oral surgeon. And you can see that from the frontal view, the right forensic reduction after surgical procedure. It was the mass of the right side is reduced because of the excision of the whole buccal mucosa. So post-surgical follow-up shows clearly visible post-surgical scarring, reduction of the right foreneck. The situation has led to masticatory difficulties for the patient, as I already mentioned, that he has facing the difficulties in eating and drinking. He has to use the straw for the drink, and also the only the mesh diet and soft diet. Now, the post-op follow-ups are very crucial for these cases because for the years, because the patient is reviewed regularly, because there is the greatest risk of recurrence in the first 3 years. And it's initially seen every few weeks for a year. For the first year, we have to evaluate and review the patient after every few weeks, like 4 to 6 weeks. Then gradually extending the review periods to few months, and in the next 2 years. And so you can actually that the literature tells us that there's every 1 in 10 patients develop second primary lesion somewhere in the urodigestive tract. So this is a very common. There's a recurrence is present. These are the source references. I use it, and there's no conflict of interest and funding in this work. And in this case, this is just my clinical case, the daily practice. I followed him from the last 3 months. And that's it. Thank you for your attention. And if any questions, please, I'm welcome to that. Thank you.
Thank you, sir, for the great informative and insightful session. It was a very great case report by you. I would like, guys, if you have any question, you can ask in the chat box, then I would address to Dr. Mustafa. Dr. Kanza has basically complimented sir brilliant case report. It was really inspiring.
Thank you. Thank you. Actually, we are doing on the daily basis. We are evaluating the patients for different conditions. But one thing which hit me a lot, and I was when I was preparing for that, a lot of literature is over there for that. We actually misdiagnose as a general dentist, and we treat the patient in the wrong direction. That is actually it's wasting the patient's time, and the consequences are all on the health of the patient. So that's why it's very important for us as a general dentist, because everyone is doing the general dentistry in daily professional life. So I think it's crucial for us to diagnose it correctly.
Yes, sir. It's a very great point, and we as a dental professional have a great responsibility, and we should diagnose it earlier. And correct diagnosis can save basically life. Anyone wants to ask any question? Okay, so there is a question basically asked by Dr. Visma. Should a dentist continue to be a primary dentist for an oral cancer patient post treatment, or it is better they are with an OMF specialist? Basically, she is asking, should we they treat this case, or should we refer to the OMS specialist?
Actually, in the daily practice, the normal patient came to you by some reference or by maybe walk-in patient or maybe somewhere else. They don't know. Actually, they think that you are the oral surgeon, you are the dental surgeon, you are treating every problem of the mouth. So patients came to you. So it's our primary responsibility to diagnose. It's our primary duty to diagnose. We have to do that thing. And we have to refer the patient to the specialist. In other words, the GDPs, the general dental professionals, practitioners, they diagnose it and they send it to the oral maxillofacial department or oral surgery department. So then they again diagnose it by confirming it with the CT scans or staging and grading. And we can do the biopsy procedures. I did it by myself, and that's all. I think we should know that.
Yes, sir. So there is a question: is there any ongoing research or development tools like AI-based to assist clinician in early diagnosis of oral lesion? It is asked by Dr. Hajra.
By AI tools, I'm not. I didn't check that actually, and that's interesting. She's asking that. We have to check that. But I was, I followed the latest research, which was in the 2024 of November 2024. So I put that data from that article. I gave these references. So these are the latest one which I followed from the 2023, 2022. There's one which was from the 2024. I didn't put it over here, but so this is the latest data. Maybe the ongoing research is going on with the AI tools and all that, but the clinical observation, the history, his presenting complaints, and these are important for the diagnosis of oral cancer. AI tools, maybe in future there are some AI tools will be available for us, but the main thing which we have to follow is the clinical correlations with the history and other specific tests like biopsies and CT imaging, CT head and neck. So and then further go to the staging and grading of the oral cancer. So this is all which we have available right now. Maybe in future we can see the AI revolution in that area also.
Thank
Yes,
you,
sir.
sir.
Inshallah.
Thank you very
Yes,
much, sir,
please.
for your informative session. Your presentation was so good, very insightful. Sir, I have a question. Sir, how can dental professionals educate patients about self-examination for oral cancers?
What do you mean by self evaluation?
For example, sir, I mean, they can just look for simple signs like ulceration or pain or bleeding in their tongue. Or is there a dental professional can educate, or it just tell a patient to self-examine?
Will tell you, the patient will tell you the history of his complaint. He will tell you, and these I showed this slide. Most common mucosal sign and symptoms present in the mouth. So if any of the symptom, any of the signs are present, anyone which patient is telling or which you are seeing, when you evaluate the oral cavity of the patient, any patient, you have to see. Sometimes patient don't know about the area or the happening. Last week, one patient came. He has no idea there is a sinus tract formation in his mouth. He was just saying there is uh, some opening in the mouth and the bleeding is coming from here. So we have to tell them or tell him or her that this is the actual the periapical infection is over there, or something else is happening over there, or there is a cyst present over there. So that we have to diagnose it by the help of history, by the help of different clinical features or by the help of different tests, the advanced tests. So then we can diagnose it.
All right, sir. Thank you very much.
Sir, there
You're
is another
welcome.
question by Dr. Shehzadi Mehak. She is asking, is neck examination important in patients with suspected oral cancer and what signs should we look for?
The neck examination?
Yes, sir.
Yes, yes, it is very important. The actually the cervical lymph nodes are present over there, and they are tender or painful, or there is maybe some swelling in that area. So it is very important for the oral surgeon or the any general dentist for the neck evaluations and all that. This is the basic criteria we have to do that actually. We have to evaluate the cervical lymph nodes.
Okay, sir. I think these are all the questions. Thank you again, sir, for your precious time, and I would highly appreciate your presentation for today's symposium. It was an honor for us to have you and Dr. Uh, Salman as well. So, thank you again, sir.
Thank you. You're welcome.
Okay, guys, then we should like proceed with our closing remarks. I think so, as there are no questions. So, with this, we conclude our this session, and we will move towards closing remarks of this session. Thanks everyone for following it from day one, and your participation has been very crucial for us. And the thing which I loved most about in this whole symposium was that you guys attended it, and we also started a virtual campaign, and you also shared it with our team as well in their own social media platforms from the day one. So thank you for making this symposium a successful. Alhamdulillah. So these were our esteemed speakers and their sessions that happened on the day one. Thank you all to our esteemed speakers and the respective hosts which hosted their sessions, including this day two as well. Thank you. Now I would like to appreciate our organizing team, the team behind this virtual symposium, who put a lot of effort in it. So I would like to mention all of each of them, their name, starting from me, then Dr. Ghazala, who is basically managing director of the team Pride, Dr. Harim, basically, who is basically associate director of Pride, and Dr. Tuba, who has been recently promoted to the position of associate director, and Dr. Saman, basically she is assistant director of Pride, and Dr. Ayman, which is regional director of Punjab, and Dr. Nazik, which is regional director of Balochistan, and Dr. Anas, which is basically regional director of KPK, and our newly appointed Dr. Hera as the regional director Sindh, and Dr. Ahmed, basically the marketing director, and Dr. Amna, who is our new information director, and all our esteemed speakers, Dr. Mirza Abdul Rauf, Dr. Salman Ashraf Khan. Thanks, sir, for being here. Dr. Saidullah Shah, Dr. Professor Numan Rauf Khan, Dr. Komal, Dr. Mohammad Ismail Memon, Dr. Mariam Fazal, Dr. Murtaba Chaudhry, Anwar Chaudhry, uh, me as well, Dr. Neha, Dr. Amir Zad, and Dr. Sundaras for giving us a pre-symposium webinars, and our international speaker as well, Dr. Carolina Benedict, which was she was present yesterday with us. Thanks to her as well. She was from South America, Uruguay, and I would like to address these three speakers as well because in the upcoming week we will also be having post symposium webinar as well, which will be given by Dr. Varda Padma, Dr. Aisha Hassan, and Dr. Doha Raja. And I would like to show you the posters as well of their. Dr. Saman, you can share the posters. of
Yes, sir.
post-webinar symposium.
Yes, sir. So these are
Yes.
the few posters that we have.
Okay. So basically, I would like to start with the poster competition. So these are the winners of our poster competition. Uh, Dr. Saman, you can basically announce their name.
Sir, just a second. Sir, I just need a little time.
Okay, so basically we divided the poster competition into two categories. One was on the basis of votes, which was basically a popular category, and the second was basically on the basis of judged by our esteemed speakers. Uh, so the one which was selected by the esteemed speakers, Dr. Saman, can you
Yes,
show
sir.
them?
So there were some posters which were selected by our votes by the audience when we share them on the screen. And
Yes,
then there
yes.
we had some uh, posters which were selected by our esteemed judges. The most popular poster winners were Dr. Maria Nawaz, Dr. Amna Riaz, and Dr. Sadia Khan. I'm extremely sorry, the screen. I hope it's visible now.
Yes, yes, it is visible. So this one was the first position by Dr. Amna Riaz, and this
Sorry, sir, it's from Dr. Maria Nawaz.
okay, Dr. Maria is the first position holder.
Yes, and I think this is from Dr. Sabah, which
And can
won
you
the category selected by our judges. The position holders which our judges selected were Dr. Kanza Ahmed, Dr. Shehzadi Mehek, and Dr. Sabah.
that's great. And Dr. Saman, can you show the post-symposium webinars posters as well
Yes, sir.
of our speakers? Thank you. Congratulations to all the winners. We will also put your congratulation posts in our social media platforms as well, on LinkedIn and Instagram account as well, after the symposium went today. And the winners have basically got the first and second and third order slots in the upcoming Researchers of Pride.
Sir, just a minute. It's taking a while.
Sure, no issue. Apart from that, we also have had a quiz competition as well on oral head and neck cancer awareness. So I would like to address that a little bit later. So these are the posters as Dr. Saman has shared on the screen. So this will be our first webinar, post symposium first webinar on Saturday, inshallah. And the topic is of future of oral cancer control, bridging research, policy, and clinical practice in Pakistan. And it will be given by our esteemed speaker, Dr. Varda Fatma, inshallah. And the timings are 8 p.m. 26th April. Okay. And the next symposium webinar is by Dr. Aisha Hassan, and her topic will be promoting oral health in underdeserved communities of Pakistan. And this will be also at 8 p.m., but it will be on Sunday next weekend, inshallah. And next one. Okay, so this will be also a session, and it will be a community-based initiative for oral cancer awareness and prevention by our esteemed speaker, Dr. Doha Rajar. And the timing are, I think so, on Sunday it is on 4 p.m. So I would request you all guys to attend it as well, so that we can finish our symposium in a style. Okay, so last thing, basically we are having I was saying that we were having quiz winners as well. So these are some of the quiz competition winners, and this is basically the first category of dental professionals. The all the graduated dentists who, including home office residents, also participated in it. So first position is gotten by Dr. Saida Tazeen Binte Nazim. Next, second position, Dr. Saman, can you scroll?
Yes, sure. Then we have
Yeah.
Dr. Muntaha Rana, who won second position. And then we have
Dr. Tehzeen Zara, which is having third position. So congratulations to all of you dental professionals for being the winner of the quiz competition, and you will be first, second, and third authors in the upcoming researches of the Pride, inshallah. And there was another category of dental student as well, but uh, for now I can just announce their name because they didn't send their picture back, so we could make a poster. So in dental student category, the uh, first position was taken by Mr. Somi Dep Divanji. Basically, it's an Indian person. Uh, so internationally, people also participated in our quiz. So it is also honor for us. And the second position was gotten by Miss Muskan Kumari, and the third position was gotten by Anusha Ahmed. So this was all the results of quiz competition and poster competition. We will also upload them on with the posters with your pictures as well on our social media platforms of LinkedIn and Instagram and Facebook as well, inshallah. With this, I would like to conclude a little bit about uh, about our this closing remarks, and I would like all my esteemed uh, team members of the Pride to join me in and say a two words on this oral head and neck cancer awareness month and symposium. Okay, so I want to address this as well. Basically, we are from the day one we are doing this, as you guys can see on our all over on our WhatsApp uh, statuses and Facebook statuses and Instagram statuses, that we are sharing it on our all our social media platforms just for the noble cause of basically awareness, making awareness. So it's very much proud to say, I can say proudly, our this hard work has also been appreciated by the and being noticed by the Oral Cancer Foundation in America as well. They have been also reposting our post as well. So it's a very much honor for our team. So these are all the posts which are created by me, Dr. Rahmat, which is our marketing manager, Dr. Uh, Amna Sohail. Basically, she was information security, but we have promoted her to information director post, and she will now be a part of the Pride as well. She joined us just for this conference, just for this symposium, and this for uh, this campaign. All the content is provided by her basically, and Dr. Ghazala as well. She is the managing director of Pride. So this is all the hard work of you can say our team, which we are posting daily, and we didn't have gotten a break, and we will also be posting today's poster as well, awareness post as well. So hopefully this our noble cause is being uh, observed by all the people, and basically it's a sadka jariya, and we all as a healthcare professional should share these kinds of awareness posts on our social media platforms. It's our moral duty as well, I think so. So thank you for seeing this. Uh, at last, I would like to share a little bit, just a video, Doctor.
Sir, that's it.
Thank you, Dr. Saman, for sharing it. I would just
Thank you very much,
share.
sir. Thank you.
Welcome. Just give me a 1 minute. I would. Okay. Basically, this video doesn't have sound, but I would like to know that is it visible, Dr. Saman?
Yes, sir.
So this is basically your team behind Pride. So as I have mentioned them earlier, but I want to see them as well. I couldn't mention some of the names, so I want you to know them by this video. She's basically Dr. Ghazala, Managing Director. She's Dr. Harim, Associate Director of Pride. Dr. Tuba Osman, Associate Director of Pride. Dr. Saman Sultan, Assistant Director of Pride. Dr. Ayman Liaquat, Regional Director of Punjab. Dr. Hira Sani, Regional Director of Sindh. Dr. Anas Khan, Regional Director of KPK. Dr. Nazik Mari, Regional Director of Balochistan. Dr. Ammar Ahmed, Marketing Director, Dr. Amna, Information Director, and Dr. Aman Zada, Research Supervisor. Dr. Mazmoon Khan is basically our research distributor. Dr. Safa Asif is our research analyst, and Dr. Haja Siddiqui is our research analyst. So this is all the team Pride in front of you guys. Thank you, Team Pride, for all the effort behind this virtual symposium, in organizing this, in marketing it, and I highly appreciate your efforts. So with this, we have just like 5 minutes. I would like to conclude the whole symposium in just 2 or 3 words. I would like other team members to speak because I am speaking it. Dr. Someone, you can start basically.
Assalamu alaikum, everyone. Assalamu alaikum, our esteemed speakers. We are very much grateful for your time, for your insights, for the information that you shared with us. It was much needed. We young professionals need a lot of knowledge to understand, as there is a lot of advancement in oral and maxillofacial surgery, oral pathology. There's so much information out there about oral head and neck cancer. Thankfully, thanks to Pride, thanks to Dr. Farooq for taking this initiative to spread awareness through this symposium. Sir Farooq, the heart of this initiative, and rest of the team, the organizing team, rest of the participants of the Pride, they worked really, really hard, tirelessly to make sure this symposium works and to make it a successful event for each and every one of the audience, as well as the participants, speakers, and the team members also. I'm extremely thankful to the audience who the audience took out their time, especially on weekend, and participated a lot. Just they were very much focused during the lectures because they asked such insightful questions, and extremely grateful. In fact, I have no words to thank our esteemed speakers, senior faculty members from across Pakistan who took out their time, made presentations, and guided us a lot about such a diverse perspective of oral head and neck cancer, um, regarding this. And I'm extremely thankful to my team. Pride is basically an organization which has so much growth. Everybody helps the other person. We together help each other, cherish each other's success, congratulate and help a lot. We worked hard as a team. And I think the success of this symposium is because of the unity and the faith that we had in each other. I think I'm
Exactly.
very short of words. I'm very grateful
Exactly.
to each and every one of you. Thank you.
Thank you, Dr. Saman, for such a great closing remarks, and you concluded very greatly. I would like Dr. Amna to speak some words as well for this virtual symposium.
Assalamu alaikum everyone. I'm Dr. Amna Sohail and I've been working with Pride as Information Secretary. I hope I'm audible to everyone.
Yes, Dr. Amna.
Okay, so it was a great honor to be a part of Pride, and it's a great initiative. And thank you everyone who participated in quiz and poster competitions. And I want to congratulate all those who won. And I want to thank all the senior doctors who presented great presentations. And I just want to say I'm highly grateful, and I look forward to more of such these symposia in near future.
Thank you, Dr. Amna, for such great good remarks. Uh, okay, guys, I am not seeing any other person right now of our team. Otherwise, I would let them also speak as well. But I am seeing your comments, and they are like very good. And thank you again for joining us, for giving your time, precious time, in making this symposium a successful. And we will also see you again in upcoming future symposiums and webinars as well. And we will try our best to deliver as much as good webinars and researches we can do as a platform is on the research base. So we will be conducting a lot of researches on oral head and neck cancer, inshallah, after this symposium. And the ones who want to join for it, you are all are more than welcome to be a part of Pride Research team as a member, as a research member or other team. Thank you very much again for being here. So with this, I would conclude today's session. Thank you guys. Jazakallah for being here. Thank you. Allah Hafiz.
Thank you.